Welcome. Thank you for joining us to the coaching courses that the Florida HFMA chapter is going to offer over the next 9 weeks. My name is Christine Fontaine, and you're going to have the pleasure of listening to me and looking at me during the 9-week session. So looking forward to having some conversations. We have a lot of people signed up for this session, so we are going to get started on time. Because we have a lot of materials to cover. We're going to ask that you please put yourself on mute until we open up for questions. The session will be recorded. We're also going to ask you to stay off of video due to that fact, again, until we get to the session part of it. So if you can turn your video cameras off, we'd greatly appreciate it. Again, we're going to record this, so if for some reason you need to leave early, or you can't attend every session that we offer in the series, please make as many as you can and understand that these will be recorded for you. So again, just one reminder for those of you just joining, please put yourself on mute and stay off video for now until we open it up for questions, okay? As we're going through the session, please feel free, if a question comes up, put it in the chat. We'll go to that first, and then we'll come back and we'll answer anything live as well. Okay, let's get started. We're going to go through 5 sections this week. I encourage you, in addition to participating in this session, that you reinforce your knowledge and get on the CRC training within HFMA and take these 5 sections as well before our next training next week. There is a significant amount of material available out there that there is no way we can cover in the 9-week sessions. So please go through that. Feel free to, if you go through it and you have a question, send me an email, or we can address any questions you have as part of the next session as well. So let's get started. So the patient-centric revenue cycle, what does that mean? This course is going to provide you with an overview of the revenue cycle model. I'll share with you that when I started my career at Memorial Sloan Kettering, as a self-pay collector, no less, and that was not an easy job, that our processes were not consumer-centric per se, didn't ensure that we enabled things like eligibility, insurance verification, etc. And believe it or not, for those of you who are currently in AR and understand AR days, our mantra was 90 days in 90. And certainly that's an unacceptable AR day right now, right? And yes, I did indeed start my career at the age of 12, just in case you were asking. So when I meet new folks and they ask what I do, I explain it as we support the processes that get providers paid. If you think about a time that either you or a family member needed care and you got an order, you scheduled your visit, maybe you got pre-registered, or you just came in and got registered. They asked you for your estimated out-of-pocket. They billed your insurance. They got reimbursement, then they billed you, and hopefully they didn't send you to collections. That is the revenue cycle. It includes all of the major processing steps required to process a patient account from the request for service through zero balance. Surprising patients with healthcare bills, like we did years ago, is not accepted anymore. In addition, we do disservice to our patients when we treat them clinically, but then financially bankrupt them with surprise billing. The healthcare consumer landscape is changing. Consumers want to know and understand in order to get a personalized healthcare experience. Therefore, understanding consumer attitude and preferences across the healthcare journey is key for not just improving the experience, but for also supporting behaviors, achieving better outcomes, and ensuring you're retaining your patients accordingly. At time of service, ideally the scheduled patient has been pre-registered and can go directly to the service unit. versus waiting in a main registration area. Consents are signed, and if not collected pre-service, agreed upon payments are made. Positive patient identification is completed, and the patient is given an armband. Unscheduled patients are non-pre-registered, have to go through a comprehensive registration process at that time. Post-service includes the account activities that occur after the patient is discharged. Until the account reaches a zero balance, such as final coding of all service providers, preparation and submission of claims, payment processing, and balance billing and resolution. This process is so dependent on the actions that occurred pre-service and time of service, and providers should invest in optimizing processes and embracing technology that avoids rework and increases cost to collect on the back end. So we're going to start opening this up for polling questions. Diane, I think I've missed it. No, sorry. Oh, sorry. So the key points, and we're going to go right to, sorry, Diane. I've been technically challenged, guys, all this morning, so my apologies, which is sad. I work for a technology company. So the key points you're going to understand after you complete section 1.1 on the CRCR e-learning should be these components of what the revenue cycle encompasses. So this is where we are with, we're going to do some polling questions now, Diane. Thank you for bearing with me. We're going to give you about 30 seconds or so. So let's just take an example, an answer here. You may or may not know it. Take your best guess, particularly those that you are currently in the rev cycle today. Probably do understand it, but what happens during the post-service stage? Give everybody a few more seconds, and then Diane will show us the results. Awesome. We're going to have a lot of people getting certified for CRCR at the end of this year. Most of you got it right. 80% final coding of all services, preparation of claims, payments, processing, and balance billing. Orders are entered as at time of service. The encounter record is generated, and then the rest are again post-service, etc. Okay? All right, come on. And I cannot now get my screen to move. There we go. Okay. Now more than ever, people are asking about the price of healthcare. They are called on to make more decisions and pay more out-of-pocket costs for the services they receive. They are looking for information they need to find and pay for quality care. Healthcare Dollars and Cents aims to answer these questions to help make the sense of price and value in healthcare. So, the voluntary practices address the area where best practices are most urgently needed, focusing on financial discussions that take place in advance of healthcare service, at time of service, in the ED, and in other care settings. They provide definitive decisions, guidance about when and where patient financial discussions should take place and who should participate, and what the topics should be. First and foremost, it should respect patients' privacy. Of course, in the ED, no discussion should occur before the patient is screened and stabilized for EMTALA. The provider-patient conversation should consist of the following: compassion, communication, written follow-up, compliance framework, and HFMA's adopter program. So this is certainly the hot topic providers are dealing with right now due to the CMS mandate to provide all charges in a machine-readable format and 300 shoppable services as well. The need for transparent healthcare pricing has never been more important due to the need to help consumers make smart educated decisions about the care they receive. In order to provide a patient with information that is meaningful to them beyond total charges or allowed amounts, several factors must be included. The type of hospital service based on CPT or D or MSD or G code, total charges, contracts or fee schedules per plan, real-time patient eligibility of patients' current out-of-pocket. Recognizing the industry's need for guidance concerning the topic, HFMA convened a task force to develop 2 policies, and both of those policies will be available within the resource sections of the online CRCR e-learning, so I encourage you to go read them. So HFMA created the Medical Debt Task Force that builds off of HFMA's patient-friendly billing work. Best practices include educate, communication must be clear, concise, correct, and patient-friendly. Establish policies and make sure they are followed internally. Be consistent. Coordinate to avoid duplicative contacts. Exercise good judgment. And then timing should be as soon as the conversation needs to happen with that patient. So which items are, so key points, sorry, key points that you want to make sure that you, as you take, again, the course on CRCR, really understanding in depth the key points that this section covers. Okay, so which items are not best practice? So we'll give you, Diane, a polling question. There you go. Thank you, Diane. So with everybody, another few seconds to answer those questions. And we'll show you the results. Okay, absolutely. Most of you got it. Really great judgment. Report to healthcare plans when patient account is transferred to collection agency, and also correct is exercise moderate judgment when communicating with providers about scheduled services. Shouldn't be moderate, right? So we need to make sure that we do it appropriately. So, all right, moving on. All right. So, sorry, we have a second polling question. My apologies. We're going to ask you another question here. Which option is not a main HFMA healthcare dollars and cents initiative? So give everybody a few seconds to think about that. Okay, Diane, let's move on. The results. Actually, process compliance. Both patient financial communication, medical account resolution, and price transparency are all part of the initiative. Process compliance is not related to that. I know it was a guess. There's got, again, as I said, there's a lot of information on the CRCR, trying to get you some understanding of type of questions that you might be presented with as well. Okay, let's moving on. At the end of this section, you should be able to speak to these 3 bullets. Patients expect value for their healthcare dollars, including greater transparency of quality and price information. Patient satisfaction also means that the patient understands the provider's payment expectations and terms. HCAHPS, that's a mouthful, isn't it? is the Hospital Consumer Assessment of Healthcare Providers and Systems Initiative. The objective of the initiative is to provide a standardized method for evaluating patients' perspective on hospital care. For additional information, you could visit cms.gov and search for quality initiatives. For those of you who did not know and have not applied yet or not familiar with the revenue cycle best practices and recognition of those providers through HFMA, this is one of the questions to determine your provider's perspective, not just AR days, etc. Of the 27 questions asked, only one question encompasses the entire patient experience, which is, would you recommend this hospital to your family and friends? It is important to go the extra mile by creating patient-friendly processes and improving the overall patient experience. Implement processes that are patient-centric and efficient. Educate patients about their insurance coverage, and an out-of-pocket can alleviate their concerns. Communicate financial information clearly, consistently, and timely. Hard cost is the loss of future revenue. Great clinical care can be eroded based on the experience in the front end and back end collection efforts. When I first started at University of Maryland, a patient called me and said that all they talk about is how, at their parties, is how bad their experience was with respect to both their front end experience and their back end collection experiences. I did want to say maybe you should probably get new friends if that's all you talk about at their parties, but I didn't. I listened to the patient's complaint and I addressed the issues that were causing those to occur. So to improve quality and decrease back-end billing insurance and back-end billing rework, insurance verification, pre-cert, and pre-auth should all be done prior to the patient walking in for service. So, staff should receive extensive training in the art of welcoming behavior. They have a responsibility to efficiently and professionally gather all information necessary to support the patient intake process. It is important to recognize that there is significant organizational costs if policies pertaining to communication, customer service, and quality assurance processes are not established, and legal issues can also arise. For example, if a patient is registered with the wrong MPI and the correct patient arrives in the ED and is allergic to penicillin and it is given to them, in addition to an adverse reaction, it could certainly have serious legal issues. So focusing on quality is key to both patient care and decreasing cost to collect. So, so the objective of the HCAHPS, I never want to have to say that again. So I'll give you all a few minutes to, or a few seconds, sorry, to answer that question. Based on, you know, again, I know we're going through a lot of this very quickly. In the interest of time, we want to also leave time for questions. Okay, Diane. Yep, to provide standardized method for evaluating patients' perspective on hospital care. That is the correct response. So good to see many of you are getting that. Cool. All right. So let's move on. So in this section, we're going to discuss departments and personnel with whom revenue cycle staff and leaders will work with in a patient-centric revenue cycle. So healthcare providers today are faced with an increasingly complex operating environment. Using and optimizing technology provides a competitive edge and decreased costs by streamlining operations, increasing productivity, accessing profitability by health plan and patient type, and providing quality care. Organizations that do not keep up with information technology may be faced with limitations on their ability to attract and retain not just patients, but staff. Common software applications include, but are not limited to, scheduling, admit, discharge and transfer systems, or ADTs, commonly referred to, pre-billing editing, electronic claim generation, payment tracking, exception-based work queues, AR management, cash posting, denials, refunds, and collection transfers. Some EMRs, I won't name them, will state that they don't require bolt-ons. Pretty much an incorrect statement from my perspective and my experience. Additional bolt-ons that I've seen used in the revenue cycle include electronic eligibility verification, estimation calculated that ensures we're getting it right for the patient and their benefits, automating the complexity of prior authorization, computer-assisted coding, charge integrity, claims scrubbers, because not all of your edits can be built within your host system. The claim scrubbers are going to do those for you if needed. Denial and appeal support, and then certainly analytics beyond what you may get with your host system. So we're going to ask another question here. Which is not a department that supports and collaborates with the revenue cycle? We'll give everybody a few more seconds to think about the areas that you're working with within the revenue cycle to, again, create that patient-centric experience. Diane? Got it. Assisted living, that's a type of service, right? It's a patient type or a type of service. It is not actually a department within the system. Great. Moving on. A lot of smart people here. Continuum of care is a way of coordinating and linking healthcare resources for facilities, facilitating a seamless movement among care settings. It seeks to implement linkages to connect patients who are leaving the acute care settings with post-acute facilities and services. The coordination of care has gained importance as alternative payment models expand to include bundled payments. The physician, dependent on this, is the physician is going to provide the order, typically schedule the service, and hopefully obtain authorization for the care based on the patient's clinical needs. Okay. So the key points that you want to come away with is the continuum of care is a way of coordinating and linking healthcare resources to avoid duplication, making it seamless for that patient to go from acute to post-acute to possibly assisted living or home care. So it's everybody working together to coordinate that patient for their clinical care. Okay. So another polling question, which option is not a continuum of care provider? Okay. Diane, we'll see the results. Health plan contracting, correct. That is a department of the hospital that's going to ensure that your contracts within your payers are managed effectively and is going to get you the most appropriate reimbursement. So good. Okay, we're moving on. Okay. So what we're going to talk about in this section is the rise in corporate compliance program, including their complexities and importance. We're going to talk about the components of the programs, the role of the compliance officer, HIPAA, including electronic code sets, and privacy and security components. Believing that organizations are ultimately in the best position of self-police. The Office of Inspector General developed the Model Compliance Plan for labs in 1997 and for hospitals in 1998, followed by a dozen other guidance documents for pretty much every type of healthcare provider and service provider, like DME and pharmacy. They're going to cover the key risk areas that are perceived to lead potential fraud and abuse, things like upcoding of MSDRG assignments, inaccurate or incorrect coding. And there are 16 essential elements that must be part of a plan. It must include self-reporting, must include a culture that encourages reporting, a compliance officer at the high level of the organization, pretty much reporting independently, typically to the board of trustees or the board of directors. Oversight, written procedures including an employee code of conduct, training, hotline, exercise due diligence with sanctioned individuals within the program, monitoring systems, and establish standard procedures. Must be in writing, must be an effective plan. That makes sense, right? Discretionary authority, independent evaluations, disciplinary measures, and an audit plan to ensure that you're following your plan. Essential elements, if you don't follow the plan, in 2017, the Federal Justice Department recovered $2.6 billion for allegedly providing unnecessary or inadequate care, paid kickbacks to healthcare providers to induce the use of certain goods and services, and overcharged for goods and services paid for by Medicaid, Medicare, and other federal healthcare programs. So pretty serious to make sure that you're in compliant with what they're putting out there. So what are the following, another polling plan, I'm trying to keep this somewhat engaging for you guys. Which of the following are not essential elements of a compliance plan? And the answers could be more, but we'll go through and see what everybody finds. Diane? Yeah. So actually 2 of them are going to be correct. So for those of you that answered automatic dismissal of an employee excluded from participation from the federal healthcare program, it really just, you don't have to automatically dismiss them, but you have to exercise due diligence. And then certainly the designation of a compliance officer employed within the billing department would also not be, is not part of the plan. That individual must be a high-level individual, again, very independent, so they're not dealing with, you know, having to deal with multiple issues, right? And so, and whether they're doing something else, they're concerned about possibly reporting. They really need to be independent reporting to, again, a board of trustees or a board of directors. We have found that, unfortunately, in this current stage, you know, obviously, I think many of us have found that staffing has been decreased, unfortunately, in provider settings, and some of the compliance officers are holding dual roles, and so they need to be even more concerned and careful that it doesn't, you know, those roles don't conflict. Great. All right, let's move on to the next section. Okay. The code of conduct is believed to be the backbone of the organization's compliance program. The code of conduct, if implemented effectively and enhanced as needed, can reduce weaknesses by helping employees and agents understand their roles and responsibilities while focusing on an environment where concerns or questions are raised without fear of retaliation or retribution. It is a living, breathing embodiment of the program. And just make sure we codify, I use the word employees and agents. So as you deploy and use outsourced agencies, they must also be very familiar with your compliance plan, and then they should be very highly concerned about your code of conduct and should be included in all of your organization's training and culture of reporting that information if they so see it. So not just your employees, but anybody you bring in to the organization. I'm seeing we're going to get a lot of questions, and I'm glad we're leaving quite enough time to go through those. Okay. All right. So the OIG was created to protect the integrity of HSH. So it is to identify and hold accountable those who do not meet program requirements. Publish an annual statement of work, but is now updated as needed on a monthly basis. So that's an oxymoron. But some examples of work plans include initiatives related to prescription opioid drug use, Medicare payments made outside of hospice, denials and appeals in Medicare Part D. Some well-known names that many in the industry should know about that were issued corporate integrity agreements included Tenet, National Health Laboratories, and U of Penn. So, organizations need to be very cautious about ensuring they're meeting the requirements and they're sanctioning employees that don't, and they're self-reporting to the government. I'll give you an example. When I was working years ago, I had a individual that let our staff know that they should change the physician and the physician MPI to get paid. And once I found that out, I had no choice but to report that to my compliance department, who then had to report it to the OIG through whatever sources she does there. I didn't do it directly. And we had no choice but to fire that member. So knowing that what she did was clearly a violation of the regulations required us. I also had another employee that in Maryland, we had very difficulties in getting paid as to who should cover it if there was any type of mental health diagnosis on the actual bill. There was a lot of back and forth between the Medicaid plan and then the behavioral health plan that covered it. So they were actually separate. And I had an employee that chose to inform our employees, manager who told the employees to switch the diagnosis codes, right? So if you put the medical diagnosis code in front of the behavioral health diagnosis code, even if that wasn't the primary diagnosis and it's not the way the physician coded it, then we could get paid through Medicaid. Again, clearly another violation to change coding on the back end just to get reimbursed. Again, reported to compliance, we really had no recourse but to fire that employee. So really important to find those opportunities and get those reported appropriately. Okay. All right. So the goals of HIPAA, I'm sure everybody on this call has heard about HIPAA, are the restriction of patient information, right? I mean, certainly expanding health coverage, restrictions of access to PHI information, and ensuring that BAAs are in place and only individuals that have a need to know can access that information. It also ensured that patients had the right to the healthcare files, request amendments, or make corrections to them. So really allowed patients to have a little bit more control of their information that's available out there, and also the access to that, ensuring it's protected. Okay, so I usually state that there is no standardization in the ANSI transaction sets. And as I've always looked at data, payers, I'll talk about eligibility, payers will use different segments and loops within, say, the the 271 response, right? And they'll have different data elements, and they'll use different service type codes. in those responses, resulting in various copays and deductibles. What we have found, what I found personally is this. Payers met the minimal requirements to be compliant with the ANSI set, right? What I found is they spend a significant amount of time on their website, and that's where they update and can control the information better. So, you know, even though the EDI, I think it's getting better, and your major payers are absolutely improving on that, there is still not a consistency in the standardization of the data. So just something to keep in mind. The final rule adopted standards for 8 electronic transactions and code sets that are used throughout the healthcare industry. Most commonly in the revenue cycle is you're going to start with the 270, 271 eligibility response. You then will get into possibly referral certification and authorization using the 277, 278 messaging. We'll then convert our claim into an 837 file, and then we'll get the ERA or the remittance through hopefully an 835 file. So those are your standard transaction sets that support the revenue cycle. The majority of the other ones are going to be related to things like enrollment and disenrollment in health plans, health plan premium payments that may not impact the revenue cycle directly. Okay. So on May 31st, HHS released its final rule, Health Insurance Reform, Standard Unique Employer Identifier. The use of a unique employer identifier is required under HIPAA. Okay. The MPI is a HIPAA administrative simplification standard. The MPI is a unique identifier number for covered healthcare providers. Covered healthcare providers in all health plans and healthcare clearinghouses will use the MPI in all of the financial transactions adopted under HIPAA. So all of your claims, all of your remits will reflect either a group or a rendering MPI number. Okay. So privacy of health information. So you need to provide training to all staff within the organization on its policies and procedures governing HIPAA compliance. Define protected health information and access thereby to individuals, payer, and business associates. Ensure the training is based on the job responsibilities of staff who handle protected health information. The only exception to training staff is an organization with a group health plan. That's the only one that we can find out there. So, okay. All right, so the Administrative Simplification Act provisions of HIPAA, Title II, required the Department of Health and Human Services to establish national standards for the security of EHI information. The final rule adopting HIPAA standards was published in the Federal Register on February 20th, 2003. Final rule specifies a series of administrative, technical, and physical security procedures for covered entities to use to ensure the confidentiality of electronic protected health information. Okay. So each healthcare organization has a compliance program. Within the revenue cycle, staff need to understand the importance of compliance with federal and state programs, requirements. Medicare program issues related to the 3-day window, 1-day window, Medicare secondary payers and advanced beneficiary notices, as well as CCI rules are keys to compliant claims processing. HIPAA requirements for privacy and security, as well as the opportunities presented through the electronic transaction set, also impact revenue cycle operations. Okay, so we have another polling question. Which option is not a work plan task mentioned in this course? Okay, Diane? Reconciliation of outlier payments is the correct answer. All of that, the other ones are included as part of the work plan task force. So good job on that. Actually, we got through that pretty quickly. So I'm going to open up my slideshow so I can see questions.
Hey, Christine, awesome job. If it makes it easier for you, I can let you know which questions still need to be answered, so you don't have to kind of scroll through that.
If you don't mind reading the chat, that would be real helpful, and then we'll answer it, and then we'll kind of open it up for live questions and feel comfortable that people can join us.
Yeah, absolutely. So there's two questions I think that are still outstanding. One of them was around the compliance program. Is there a list made available either through the slides or through the coaching material or the content online?
The content online is going to be your most comprehensive. We're trying to keep this we'll know some of the sessions are going to go over the 45 minutes that we're trying to keep most sessions on, but we want to make sure these are comprehensive to you all. So, I'll re-engage and say, one, if you're an HFMA member, the coaching course is free to you. If you go to try to sign on for CRCR and ask you for payment, you should create an account and log in to HFMA with your member number, and then enroll in the course itself. And it should be free to you in your e-learning courses. If you have an issue with that, I highly recommend you read National HFMA. If you're not a member, you will not be able to sign up for the course free of charge. So I highly encourage you to join as a member as well. So there's just no way we can get through the entire course in the time that we're here. For me to walk through the course in the 5 sections and then read through the comprehensive material took me a few hours of going through each and every section. So.
Great, thanks, Christine. The other question was around, when was the last time the CRCR course material was updated? I don't know if National does it like on an annual basis or.
So it was actually just updated this year. And there also is additional information that National Certification informed me that they're going to be sending out. So I've been in touch with Shirley Heblin, who's the National Certification Chair, to keep us informed of any materials that are available. So they're pretty good about sharing that information and giving us the materials to create a comprehensive discussion. So it's recently this year, and there's additional work happening both on CRCR and CHFP.
Awesome. One question just came through the chat. Can you tell us a bit more about the testing process? Is it proctored, online, etc.?
It's online. Yeah, you're just going to go in and complete the assessment accordingly. I do not believe it's proctored. I do not have my CRCR. My intent is, as I go through these sessions with you all and learn it, as I said to Govi in the beginning of it, I've been in RevCycle so long that I forgot so many of this stuff. So it's kind of nice to go back and do it again. My understanding it is a assessment that you're going to do online. I believe it might be timed as to completing it. As you go through the CRCR sessions online, that's where they're going to have some questions for you. They're going to prompt it to ask those questions. Again, it's very comprehensive resources that you can reach through as well. And we're here for you too. As you go through those sessions and you have a question, either email it to me and I'll answer it live, or I'll bring it to the following session and get the entire team a response as well.
Great.
Okay, Govi, anything else?
I think that was it in terms of the questions. There's some next steps you and I can chat through in terms of post communication out to the attendees.
Sounds great. Okay, do we want to open it up for any live questions? If anybody there has a question and they want to take themselves off mute, certainly feel free to share your video. Please open up your mic and put your question out there if you want.
As I just mentioned, that there's a few questions that came through. I don't know if you want to look at the chat box.
Let me see if I can get that. Yeah.
Otherwise, let me know and I can I can relay it over to you.
Yeah, some of the questions, can you work ahead and take the test earlier? Absolutely. You don't have to wait for it to do it. You can take it tomorrow if you feel that you're ready. This is intended to do two things: help those that need the support, and also motivation to actually take the exam. I spoke with a lot of people that have said, hey, I want to take the test. I've been meaning to take the exam and get my certification, and I just keep on putting it off. What we're hoping this does is give you a way to motivate yourself to actually take the test and the exam. So the question about the PowerPoint, that will be put online. So you will have all of the polling questions available to you. Most of those questions actually came from the certification online. And so if you go through that, you'll see the same questions and answers that we went through today. Some of the benefits for obtaining your CRCR, we did a session about that and why you should get certified a few weeks ago. We recorded it, and it is on the HFMA YouTube channel, but really promoting yourself and showing your dedication to RevCycle to your leaders. And hopefully brings you up, allows you to move through your career path, are just a few of those. Plenty more beyond that. So I am not, there's some here that I'm going to have to go back and review about things like practice tests and stuff like that. So we'll make sure we get a comprehensive list. Again, the handouts will be posted, I believe, on the Florida HFMA website. But we'll get that out to you after the fact as well. Okay. All right.
Christine, this
Yes.
is Cheryl. I was wondering, is it more beneficial for us to do certain segments of the training online prior to attending your coaching?
I think it's going to really depend, Cheryl, on everybody's individual learning. What the intent of this is to understand the key concepts, right? So if you feel more comfortable taking the full assessment, and we're going to do probably 5 sessions this week, 5 sessions next week, just to get through Unit 1. When I get into Unit 2, I'll be sharing with you how many sessions we'll go through for those. And then our last session is intended to kind of do a recap and maybe kind of have some practice exams out there that we can create for you. I don't have visibility into the questions on the CRCR, so certainly I can't give you those. I think if you go through these sessions and do some self-studying, you'll have no issues with passing the CRCR and getting the certification. So Cheryl, to answer your question, I know that was a little vague. I really think it depends on the learning style of an individual.
Okay, thank you.
Okay. All right. All right, so we'll walk through these and see if we have any other openings. The list of the 16 compliant elements are on the online CRCR. So you can go through those as well. I don't know if the CRCR actually will have 2 potential correct answers. I will let you know as soon as I know. Okay. I would say no, but these questions are intended more for training, not necessarily for this is what's going to be on it. Okay. So now, in the interest of time, we want to give some time back to everybody. But I also know I have another, let me get out of the chat, Gobi, and I will bring up your, I don't know why I'm not getting, there you go. Your, give the mic to you. There you go.
Thanks so much, Christine, and thank you everyone for attending this session. This was really great. I already got my CRCR, and I wish I had this as a way to help study and prepare for the testing. I am going to get my CHFP, and I know we're going to do a lot of these coaching sessions for the CHFP as well, so I'm excited about that coming up. So I just wanted to thank everyone for attending this session, and I also wanted to talk about some exciting things happening with the Florida HMA chapter, some things you might be interested about knowing and registering for. So we have got 2 events coming up in the month of October. Sorry, give me just a second. I'm getting a phone call here. There we go. We have an event coming up on October 15th. We're calling it Who's Behind the Mask. Registration is open up for this event. This is going to be an event that's all about leadership and volunteer engagement. So if you're interested in kind of building up your leadership skills and you're interested in maybe getting involved more with the Florida chapter, maybe volunteering on a committee, this event is for you. We have Kelly Nichols, who's the Chief Integration Officer over at Bon Secours, who's going to kind of kick things off and give a 1-hour session around leadership. So it's going to be very inspiring and engaging. So definitely encourage you all out there, if you're looking to kind of disconnect from the office and day-to-day stuff and kind of learn more about what's going on in the chapter and how to get involved, this event is a good opportunity for that. The other event we have coming up in October is on October 30th from 10 to 4. This event is also kind of a multi-purpose. We're going to have a bunch of education content around pricing transparency, accounting and tax trends. There's also a session on the voice of the customer. And then there's during the lunchtime on October 30th, we're going to have a fun kind of name that tune networking session, which is also going to be really exciting. So just these two events are available for you all. You can go on our chapter website down here, floridahfma.org/events for more information and to register. But thanks again, Christine. Really looking forward to future coaching sessions, and it's great to see this type of turnout and engagement. And I'm really enjoying seeing all these questions come through the chat box.
Yeah, so we'll get answers to everybody either via email, or we'll go over the next quick session. So a question just came up and I'll answer it real quick. Are the rules the same for all states? Yes. You may have your own state regulatory requirements that are not federal, but every other, pretty much the laws that we talked about are federal regulations and will comply in every state. Okay? That we'll get answers to any other questions we didn't be able to answer today, okay? Thank you guys for your time today. I look forward to next week. Any feedback would be great too. Thanks.
Thank you.
You're welcome.